great privilege for me. And so hopefully I can share some things that are helpful from my experience. So we'll see if this cookie thing works. Oh, kind of works, yeah. It's a bit slower. Okay, so I have nothing to disclose. And two simple objectives today is just learning an approach to assessing pain in children who have severe neurological impairments and communication impairments. So really just getting comfortable with these patients and understanding when and how to use a few reliable and individualized pain assessment tools for nonverbal children. So you all know a lot about probably severe neurological impairment in the central nervous system. There's a variety of etiologies. It results in lifelong intellectual disability and often limited verbal communication and often coexisting motor impairments. So the intellectual disability is often at the severe end with significant limitations in communication. And in cerebral palsy, we might see this often, in more severely affected gross motor function classification 4 and 5 individuals. In autism spectrum disorder, it's always important to think about the other areas and domains for them, such as their language, their intellectual kind of functioning, and then their emotional regulation. And in this group, the pain frequency and severity are a significant issue. So about 90% have recurrent pain lasting more than a year, 75% have the pain at least weekly, and for 50%, the pain episodes can last more than 9 hours. So the take-home message from this slide is that this is a very heterogeneous group with varying and atypical expressions of pain based on their communication abilities. So it's often helpful to have, a good lens and to think about, a simple picture. So if we assess communication abilities from a developmental framework, we think about crying in a newborn baby. And for those of you who have, children or have been involved in assessing, babies, you know that babies have a cry, but there's different kinds of cries. There's like the, I'm really hungry, feed me now cry. I'm kind of bored, play with me, whimper. Then there's my diaper's wet cry. And parents actually get to figure that out after a little bit. They'll know exactly what their baby is communicating when the baby cries. Others of us may not be as sure, but it's a similar kind of picture when you're assessing a child, with severe neurological impairments that usually the caregivers know them really well. And as a clinician, we're trying to figure out that piece, with the history and with our observations. So let's say you meet your new patient, Jenny, and you want to think, does Jenny respond to her name? How is she responding when I'm, interacting with her? Is she in a verbal kind of stage of development? Is she more in the symbolic stage, which is like a 1 to 3 age equivalent? Or is she kind of pre-symbolic, where, she's not using gestures or words, and so she's kind of in that below 1 year age equivalent. So it's a good thing to think about as you're starting to interact with your patient, reading the chart, talking to the caregiver. So I have a little vignette in my clinic where, I saw a 13-year-old boy, he has severe intellectual disability, minimally verbal, and lots of self-injurious behavior. Now, I saw the self-injurious behavior when he was coming into clinic because he didn't want to come and see me in my clinic. He didn't want to come into the room, but it only lasted, for about a minute, and then he kind of, kept going. And when we do a history, we often want to think about the function of behavior. So I know there's this concept of neuroirritability, which we think, they're crying, they're upset. And is it from pain? But another question that also to think about is it could have a specific function if we think about what happened before they started crying, what happened after. And so it's thinking about the function of are they maybe trying to get access to preferred items? Are they trying to escape maybe a demand that they don't want? Are they trying to get social attention? So those are some things to think about. So for this child, he started to have these behaviors at night when he was in bed. And the mom reported that they were quite intense and they lasted quite a long time. And that usually he likes going to bed. He likes relaxing, chilling in his bed. So she said that this was a bit unusual for him. He was, not quite consolable. And so we started wondering, was he having some nociceptive pain at night? Was it maybe GERD or reflux? So we'll come back to that case a little bit later on. So I think a very useful approach to pain in this population is asking a question based on a known painful incident, because that's kind of like your gold standard. You saw something that was painful for the child. They got a needle, they fell down, post-op. How did the child respond and what were their behaviors like? Because something painful has happened. And so we get a variety of responses from very clear, pointing to where it hurts, talking about where it hurts, to, crying, to maybe not even reacting to the pain. So that's a useful baseline to know about. So in pain behaviors in this population, you really want to look at the nonverbal communication. This is especially useful for those who are pre-symbolic. So seeing what their vocalizations are like, the intensity, the volume, their facial expressions, consolability, their interaction. you often want to also just know what are their behaviors like when they're happy, what are their behaviors like when they're content, because you're kind of getting to know the individual, and you can kind of think, yeah, these are more like real pain behaviors because they're quite different from the behaviors at other times for the child. You're looking at their tone, their movement, changes in physiologic things like their appetite, their sleep. And so this is a really important pearls. You ask the question, is there a change in these behaviors from baseline? Because that often pushes you to think, oh, maybe there's something new that's happening that we need to figure out. Could it be pain? That's the cause, or could it be another function of behavior? And I think I was chatting with one of the fellows from complex care a few weeks ago at Surrey Place, and she was saying that this differentiation of thinking about the function of behavior is not something that maybe happens as often, in kind of a pain clinic setting, in a complex care setting. And so we talked about some questionnaires for, thinking about function. So as you're interacting with a child, you want to really think about the child's developmental and communication level. And as I said, you're thinking, is the child verbal? Are they in the symbolic stage? Or are they in the pre-symbolic stage? And one of the things that people recommend, for example, in England, is they have a communication passport for children, so that if they are having severe neurological impairments, a caregiver who knows them well creates a passport saying that this is what my child's like when they're happy. This is how they communicate with their facial expressions, their vocalizations. This is what they're like when they're hungry. This is like what they're like when they're in pain. And that way, clinicians, the teachers all get to know the child a lot better. So one thing to keep in mind is there are often atypical features in this population. You might have blunted facial expression, so no facial expression when they're in pain, laughter, breath holding, or self-injury, which is quite, different, but it could be all expressions of pain. So there are assumptions that can interfere with identifying pain. I won't go over it in too much detail, but sometimes people will under-identify pain because they're not recognizing the atypical presentations of the pain, or they think that the behaviors are maybe from the child's underlying condition, that because of their autism, they're acting like this, or their intellectual disability. When clinicians use the label of neuroirritability or agitation, it can sometimes shift the focus away from the pain in a specific area and a specific treatment versus, a pain behavior. And also, looking for the increased tone and movement for spasticity, is that a result from the spasticity or is that a result from the pain? And over-identifying, which is much more uncommon, sometimes parents, depending on their past, or caregivers, depending on their past emotional experience, can alter the perception of pain in their child. And I remember a child like this where we had to admit into sick kids, and I think the nurses had to kind of observe the child, write their notes, and we had to look at heart rate and blood pressure and kind of teach the mother that, he's actually not in pain. He was just, a little bit upset about something, or he was, maybe having a bad dream, and that she learned that, oh, maybe he wasn't in pain because she was going to the emerge multiple times. So I want to go over just a few tools. So I'll talk about each of these in a bit more detail, but there's the revised FLAC, which is the Face, Legs, Activity, Cry, Consolability Scale. This is a scale you can use really quickly, and it comes up with scores. There's an individualized numeric rating scale, which is really nice because it focuses us and gets us thinking about the individual and how they express pain. And then there's the non-communicating children's pain checklist, post-op revised, which has many items and good sensitivity and specificity. It takes about 10 minutes to complete, and it also asks the person who's completing it to rate the behaviors over the last 2 hours. So sometimes that works really well for caregivers, but not as well for the nurse who's in and out. So there's nice cutoffs there, and there's a web link for that. So the important consideration is to really try to individualize for each child and to really use the caregiver parent knowledge who is the expert of the child. So this is a bit of a view of the FLAC where you can see kind of the categories of the different face, leg, eggs. You can see the score and a bit of the scoring key for each one. So you can go through and kind of circle that. And so, yeah, I can do it fairly quickly. I'll go on to the next one. They also had a little separate category, for comments when they did their study, and about 21 of the 52 caregivers in the study added individualized behavior. So I think this is a great piece to add, for all the patients if we really want to do, patient-centered care. And so there's some different examples there for pouty lips, clenched and grinding teeth, eyebrows are furrowed, stressed-looking, stern-faced, eyes wide open, look surprised. So it's really nice to have that because it really keys, I think, clinicians to look for these things when they're assessing the child. There's all these little lines there. Okay, so individualized numeric rating scale. So this is a study that they just really wanted parents to kind of write specific things down when the pain got higher and higher, what would the child look like? And I think this is very helpful. We use this often in behavioral kind of escalations when we ask people to write down child at different stages of being, a little bit upset, quite upset, very upset. What are all their behaviors and expressions like? So I think this is a good tool to incorporate, quite easy to incorporate in any assessment. And then finally, there's the non-communication children's pain checklist, which I mentioned in his observation over the past 2 hours. And it kind of goes through the different vocal criteria, social criteria, facial criteria, and is talking about how frequently these are being observed over the last 2 hours. So these are the other categories. So the level of activity, are they moving different parts of their body and limbs? Physiologically, are they having some of these changes? And then eating and sleeping, is that changing? And then you can score each of the categories and come up with a total score. So often in this group, our major concern in my clinic is often assessing acute nociceptive pain because the children are kind of going on with their lives. And if they have a new onset medical disorder, whether it's a fracture, a dental abscess, foreign body in the nose or ears, we're trying to figure out, is there something that we should be figuring out, localizing and treating, because that will improve their behavior significantly. So the other common things to think about is, otitis media, pharyngitis, common things being common. Often these children may be quite resistant to dental care. So they have dental caries, corneal abrasion, hair tourniquets. GI issues are really common. So often thinking about GERD, gastric ulcers, pancreatitis, cholecystitis, UTIs, thinking about MSK, things like hip subluxation or fractures, testicular ovarian torsion, appendicitis, and then really kind of thinking head to toe as you're doing your history. If you can palpate head to toe by yourself, but the caregiver can help you with that. Sometimes that's easier for the child to assent to because they're not as stressed out. And then you want to think about the chronic pain, in this population. So I don't see this as much, but some of the potential indicators, and we'll talk about, I think later on in the case, is a long-standing history of irritability and agitation that even happens, when they kind of should be happy, when they're doing things that they enjoy, like eating or playing with a toy or listening to music, things that they usually like. And so for this, you might be considering, repeated tests and interventions for the common problems to rule them out. And the common test would be often, we're examining them, trying to see whether that, increases maybe the pain from spasticity, or sometimes we treat them and we see, is there an improvement, in their pain from treatment, over the following days when you start a treatment. Also consider problems of TNS that are sources of pain or have features that include pain behaviors. And so there's different other problems that keep in your differential. And also keep thinking that more than one source of pain may coexist. I put a little slide up on spasticity, tone, and cerebral palsy. I don't deal with that a lot at Surrey Place, but my colleagues, the developopeds, do a lot of that at Hull and Bloorview. And there's a great pain toolbox that they have there, so I have a little link there for that. And spasticity and dystonia can be the direct cause of pain, and so it should be assessed, see if it's worsening, and then we can treat that. Or sometimes this is worsened secondarily to another chronic pain source. So trying to figure that piece out, keeping that in mind as well. Keeping in mind hip subluxation from exam and x-rays. So I'll talk really briefly about treatment of pain in the children and youth with a severe neurological impairment. A lot of the focus is, going back to the WHO analgesic ladder, has been adapted a little bit. There's no standard approach, but the empirical medication selection for persistent pain inhibitors are basically thinking of safety. We worry about side effects. This is a population that can't communicate to us if they're feeling different side effects. Whatever information we do have from efficacy and evidence from adult studies or pediatric studies. So for example, a gabapentin trial, perhaps before using a tricyclic or methadone. So you can consider this treatment in parallel while considering more invasive testing, just to figure out what is the cause while you're trying to think, well, provisionally it could be this, so let's try to treat with this to see whether this improves. So interventions for pain include daily management of the discomfort, daily assessing, looking at the impact of changes in interventions. If we started something, what are the changes? And then some of the meds, there would be something that we would routinely think about. So in terms of the 13-year-old boy, just to end up the presentation, we worried about GERD, so we started Prevacid for him. We referred him to GI. His intense self-injurious behavior decreased after a few weeks. He had endoscopy that found ulcers in his stomach. And, we were quite pleased the fact that, we helped him figure this out. So I'll just stop there. Any questions?